First of all, on day 4, there's many things that you should have already happened right now. In other words, this is when people pretty much will accept the care plan that you offer in the terms with time and money. This is where it should happen. Now, it will not happen if you have not done a few things, or it won't happen as well if you have not done a few things. So let me just point out a couple of those things. If you did not get the primary chief complaint, and you did not get the primary physiological restriction, you are going to have more trouble with that patient, because that is the motivating factor. The highest motivating factor of that patient is not only, remember the 4 components is you're always going to want to integrate is within your patient education, and the 3 phases of healing is always the patient's name, the symptoms, the chief complaint, the physiological restriction, and then always engaging in the reversal. So you're going to have more trouble if you did not do that in the consultation. If you did not find the primary complaint or the primary restriction or physical limitation, you're going to have more trouble with that. And so secondly is, remember, patients purchase, not just patients, but human. We're talking about human behavior. We're not talking about this. This isn't chiropractic. This is just human behavior. So we all purchase, and we all want to run away from pain and toward pleasure. And remember, over 80% of our time and money is spent on running away from pain, the primary and secondary pains. Primary, and again, this is based on Maslow's hierarchy of needs. Primary being food, shelter, oxygen, and sex. The secondary being security. So those are all the things that we strive for physiologically, and where we'll spend 80% of our time and money, and is the absolute highest motivating factor of the 5 motivating factors, which is present pain, future pain, present curiosity, present pleasure, future pleasure, and curiosity. So it's vital that you got those. Now, what else should have happened at this particular point? Well, you should have, this is the subconscious buyer cycle. So remember, we as consumers buy products and services in a cycle of 4, and it doesn't matter if it's a candy bar or a large purchase such as a home. Subconsciously, psychologically, we will go through 4 stages. There's first the needs analysis. Second is the presentation. Third is any obstacles. And then 4th is closure or the summation. So you're in the summation right now. You are in the 4th stage of the consumption or the cell cycle or the purchase cycle of a human being. That's where you're at right now. So you should naturally be in their natural purchase cycle. You should naturally be in their highest motivating factors and their primary, the thing that's most important to them. You should definitely have let them know. And when we talk about pain, we're also talking about consequences. And so consequences, present and future consequences that are pain-based, are vital. They're vital human motivating factors. Most of everything we do on a daily basis is trying to avoid negative consequences. So the sharing the consequences with the patient and connecting them to the 3 phases of healing. And by the way, that it's all true. There's nothing made up. This is all true. So the consequences. So what else should have happened up to this point? Well, you should have definitely established the primary need. You should have definitely established the primary restriction. You should have definitely have been in the subconscious cell cycle, the 4-step cell cycle with the patient. You definitely should have affected the 4 major factors of a paradigm, which is defenses, resistance, trust, and confidence. In other words, each multiple contact in each of those days, trust should have significantly be up on this 4th day versus the 1st day. Trust should definitely, trust and confidence should definitely be much, much higher on this day versus the 1st day. And then your defenses, the patient's defenses and resistance should be much, much lower than this. Okay. What else should have happened? The patient should, remember, people buy cognitively. They purchase, they act emotionally, they justify cognitively. So retention is a cognitive process, not an emotional process. The process of acting, buying the candy bar, becoming a patient, acting to go to an office, to buy it. Those are emotional. And then it's the cognitive justification. So the retention process is a total cognitive process, not an emotional process by far and large. And so we also tie the 3 phases of healing to the patient's primary need, because that's exactly what's going to happen, number one. But there's a natural dynamic with the 3 phases of healing, and that almost all of us will naturally heal, but we will all almost always naturally heal wrong unless we have certain physiological therapeutic effects that are introduced in each of the specific phases. So you should have accomplished quite a bit right now. This relationship, and I've said before, the need should already be very clear. Now, one last component relative to day 4 is you should never be introducing anything new in day 4. And the reason for that is you're specifically going to ask for time or money. But when you introduce anything new, you're allowing the opportunity for the person to go into rejection and have their defenses go up. Because remember, new things create unfamiliarity. Unfamiliarity challenges security. Security is the second highest need of a human being. So the natural mechanism of something new and fresh is to back away, not to move in. So you do not want to be introducing any new concepts, ideas, nothing. Do everything you can not to introduce anything new on this day. So it should be a total summation of literally each of the 3 days. Nothing new that they should be hearing at all. And also, I'm not going to be covering how to handle the spouse in this video either. That's a separate video also. So this is kind of a bare bones step-by-step and a little bit of the principles behind it. So here we go. So when the patient comes in, so we're at a much more evolved position in this relationship with this patient and their willingness, understanding, and acceptance. And the analogy that I give is on a scale of 1 to 10, 10 being high motivation that they'll spend, exact the time and money, versus 1 being very low. Somewhere in there, they should be there. They should have a crystal clear understanding whether you took them from a 3 to a 4 or 5 to a 6 or 6 or 7. Because remember, the natural dynamic of the human being is to suppress pain, suppress problems and issues and confrontation. That's the natural dynamic of the human being. So if you're not establishing these benchmarks of negative consequences, their natural consciousness wants to suppress, minimize, and deny. We meaning human beings, are constantly wanting to minimize and deny problems. And that's the natural dynamic of what patients will do. Now, if you don't change that, that's what you will naturally get. And when they minimize their problems, they're not willing to spend time or money to take care of them. So you're not trying to exaggerate the problems, but you have to bring them and maintain them at a consciousness, not a subconscious, because they want to drive it down. They don't want to deal with it. So having said that, in day 4, we're going to, the patient should already have a pretty good, clear understanding of where they're at with motivation, whether it's a 5, 6, 7, 8, 9, wherever they're at. And you should have been very good as a communicator in being very clear in establishing that with the patient. So that's vital. And one of the major components, remember, of educational sales or patient education is people have to go through 3 phases of awareness. They have to admit it, that there's got to be consequences of the consequences. Remember, there's 5 types of consequences. Present pain-based consequences that are of a primary nature are the most motivating factors there are. And then there has to be the personalization. And that was also why this should have been personalized. Their condition should have been personalized to how they heal with the possible consequence, the comparison, contrast with consequences. That's a total cognitive argument. It is not emotional. And it's a small paradigm shift. So we chunked it because when we create too much, it also creates a defensive resistance mechanism. So that's why we also did stair stepping. So there's multiple things that happened through this whole dynamic. So they should be at a particular position with their motivation, whether it's a 5, 6, 7, 8, 9, 10, wherever it is. It should be established. Now, the analogy that I always give is, all you need to do, wherever it is you took them, all you now, it's remember, people buy based on the relationship of their perceived need relative to their obstacles. And we say the obstacles are always time and money. Always time and money. Money more important than time. Divided by trust. So the 4 days have had and should have had a significant impact on trust. You should have been able to establish need very well, crystal clear, with absolute simplicity. That's what you should, your communication. That's how good of a communicator you should have been. And they should have understood and agreed with everything instead of you just talking at them. And it should have been interactive, where they admit it, they understood consequences, and it was personal. And that's the style you should have communicated with them. So wherever they're at, let's say they're a 7 on a scale of 1 to 10, then the only thing that you need to do for them to agree with your treatment plan and time and money is to be 7 or less. That's all you need to be. Now, the good news is when you deal with obstacles of time or money, you got a couple options. With money, it's either price in full or go to terms. So the key, the absolute key to understanding retention is not think that you can get everybody up to a 10 in need and get everybody up to a 10 in their willingness to pay you everything you want them to pay you. That's called absurdity. That's ridiculous. The key is to solidify and establish their need, whatever that is. It does not have to be a 10. They do not have to be a 10 for them to agree for your terms of price and money. They do not. All that needs to happen is it needs to be solidified relative to the obstacles and specifically terms. So the key is to be able to go to terms. Now, when you've established a need and you've taken it to wherever it is, 4, 5, 6, 7, 8, whatever it is, the absolute key to the agreement now, and a high percentage of agreements with people accepting your recommendations, is not the price. That's not the key. The key is the terms. That's the key. So it's increasing their perceived need, because remember, what are they always trying to do? They're trying to always push it down, minimize and deny. You're not trying to increase them. You're not trying to do anything false, because remember, they will see if you try to do anything subversive and violate their trust and prey on fear, they will also fire you. They will also reject you. So you have to be completely honest with the situation. And that's what's fortunate about 3 phases of healing, is there doesn't have to be any perception. That is reality. So the next key is going to terms. So you got to be aware of that. So if I had a patient that was a 4, my terms just need to be a 3 or lower. If I have a patient that had a need that was a 7 or 8, my terms just need to be 6 or lower. That's all. They need to be better than the need. That's all there is to it. That's what will create the relationship. And we're also going to assume that trust was not violated, that trust was actually accentuated through the process and not violated. We're going to make that assumption. Obviously, if you violated trust anywhere in that relationship, everything I just said, you can just throw out the window. Doesn't matter. It's all over. It's not going to work. Nothing works when there's no trust. So, having said that, let's go through the steps. So, number 1, obviously there's the introduction. Okay, so you come in office. You're going to remind them that that visit's going to take longer, because you always have to remind patients. So you got to remind them that that visit's going to take a little longer. You're going to take time out to go over the results of their exam and x-rays and see exactly what it's take to get them back to normal, or as much as their problem will allow. So we reminded them, number 1. Number 2, we're going to do a quick review on the board. So when the patient comes in, we do the introduction. How's your day going? Blah, blah, blah. We're going to remind them. Number 2, blah, blah, blah. We're going to take time out. Number 3, we're going to go to the review on the board. Now, so after the review, the review, and the review is not interactive. The review is a checkoff, and I talked about a different video, the techniques of delivering information. This is not an interactive session right now. It is a complete checkoff. Check, check, check. If you remember, and that's what it would sound like. So, Mary, let me just review really quick how your body's going to heal, how we talked about how your problem's going to heal, and how it's going to get back to. Remember, your body heals in 3 different phases. There's the inflammation, repair, and that's just up at the top. You can just leave all 3 of those words at the top of your whiteboards. You shouldn't even have to erase those from left to right. Those 3 words, just leave them up there. And then real quickly, you're just going to write in the 4 negative components in the repair phase and just check them off, and then just remind them in the inflammation, in the remodel phase, that we're going to remind them of the consequences, the pros and cons of those 4 negative things, and then how it is affected in the remodel phase relative. And we use the example of the mop and the cement, where it actually starts to solidify. So it will heal. Now, whether it's going to heal right or wrong depends on what happens therapeutically, but you will heal. Okay, so that was our reminder. That's how quickly and that should be. Now, we come back, and this is when we're sitting face to face. Again, proximity is important here. I do not want to be on the other side of a table with an obstacle or a barrier between us. This is when they're in the chair. I'm going to sit down right in counter right in front of them, and we're going to start walking through. And it's like the fireside chat type of thing. It's a very personal, me to you kind of interaction. So the first thing we're going to do is review the history, a quick review of the history. When you first came in here, it was blah, blah, blah. And you're only going to pay attention to the mechanism of injury. The mechanism of injury. You said this happened, and this happened. Then you're going to go back into the frequency and duration. How long has it been going on? How long has it been going on? The conscious and subconscious duration. Frequency, once a week, twice a week, 3 times, and intensity. That's it. So we're reminding them of the pain, the motivation. So that's the history. So when you first came in, mechanism of injury, you said initially it was this. When I talked to you further, we turned out it was this. And it resulted from this. What was the anchor? What initiated it? What was the frequency? What was the intensity? This is all, remember, because they should be starting to feel better, but also what happens with time and pain. We push things down over time. We suppress them. So you're just helping to keep things at a surface consciously. That's all that's happening here. So, and all of this should have been in their words. None of this should have been what you extrapolated. So you said this, you said this, you said that. Okay. So that was the history. Then we're going to go into the exam. Now, are we going to go into every part of the exam? No. You're just going to primarily go into the positive components of the exam. Now, we're very careful, and I say, when you use a positive, a lot of times you always want to compare it to a negative, or not a negative, state the opposite. State what it should be or shouldn't, what should be normal versus what it was. Remember, patients don't know what's normal. Now, I have to remind you right about now that you're communicating with them verbally. What does that mean? You're communicating with the worst form of communication there is. Remember, 7% of communication are the words. You've got to remember that words are the worst form of communication. So what is important here also is to show them, if you have the exam card, to show them, okay? Now, these are what are called the biomarkers, the biological markers. You want to definitely identify biological markers, definitely. Now, there's some common biological markers that I highly recommend and that are very common with chiropractic. What are the most common biomarkers with chiropractic? Well, range of motion is one. Range of motion, especially with overpressure. Overpressure affects passive and paraphysiological joint space. So if you never do overpressure with range of motion, you'll never have those lesions, and that's where the majority of the lesions in the positive tests are. If you just did active range of motion, you're going to miss much. So range of motion, that's a biomarker. So overpressure with range of motion, overpressure with range of motion, that's a biomarker. What else is a common biomarker in chiropractic? The compression tests. If it's the neck, it's the foraminal compression. If it's in the back, it's the Kemp's test. The two most common tests that are positive in a chiropractic office is extension range of motion, and compression, because we're specifically putting app pressure on the joints. So you should be putting a lot of emphasis and focus on those tests and make sure you're getting them right in your initial exams and re-exams, etc. Those are common positive tests with chiropractic. Now, in addition to that, so we talked about the history. You're going to go into the history. From the history, you go into the exam. We're going to point out just the positives in the exam. We do not want to go into everything we did in the exam. We do not want to do that. We're going to go into the positives, and when there's a positive, you might want to state the opposite of it, which was normal. In other words, if it was a positive foraminal compression on the right, then I will point out that when we did it on the left, it was normal. See, that's the difference, as opposed to just covering every test that I did with this person. No, I'm not going to do that. Those are going to be insignificant. The tests that are meaningful to them are the ones that are positive. Now, I'm going to talk about later also what's called third-party trust factors. Third-party objective trust factors, and they are very, very important for chiropractors to understand and use. Third-party, multiple, visual, third-party trust factors. That's a whole different topic. So I'm going to cover the biomarkers. I want to put points of emphasis on the biomarkers. In other words, I want to tell the patient that these are the top 3 or the top 4, or these are the top 7 indicators. In other words, you want to be very clear with this patient that this is exactly this highly confined area of these 2, 3, 4, 5, 6, 7, whatever. In other words, you pick your biomarkers. And the common ones I just told you are range of motion with overpressure, Kemp's test, orthopedic test. Typically, if there's any sensory deprivation, there's hardly ever any reflex issues. There's hardly ever any true muscular weakness issues. It's typically from pain, not from a true neurological deficit. That is absolutely rare as can be in a chiropractor's office because of something called market forces. So you will typically rarely see decreased reflexes and decreased muscle strength in a chiropractor's office due to a true neurological deficit. Those are very rare because of market forces. When people have neurological conditions that do have that type of an impact, they typically are not rushing to a chiropractor's office. They are in other market forces directs them elsewhere. That is not the standard chiropractic. So I do not recommend using as your biomarkers tests which are highly unlikely to be regularly positive. Let me say that again. I do not recommend using tests that are highly unlikely to be negative as biomarkers. And those are 2 classic examples. So what are the tests that I would recommend as biomarkers? Well, these are the ones that I use, and this is why and how. 1, range of motion with overpressure. And that's in each area of that chief complaint. 2, compression test. 3, orthopedic test. And that might be Lasag's or Valsalva, something like that. 4 is x-rays. 5, blood test. And I understand many people don't do blood tests. And the blood tests I'm referring to are called inflammatory indicators. And it is the single greatest biometric marker you can use. Not just from a clinical standpoint, but from a patient trust standpoint. And I'm not going to get into that right now, and I don't want to confuse the issue. So if you're not using or doing blood tests, don't worry about it. If you don't want to do blood tests, don't worry about it. Don't do them. On a separate video, I'll explain biomarkers specifically and the importance of visual third-party trusted biomarkers. And the only point is, all of those tests that I just explained to you, the blood test is the most authoritative, most trustful test that patient will listen to. You can say x-rays. You'd be surprised how many people do not even know what an x-ray is. They don't even know. It's interesting. Some of them can see obvious things, but there's still not a huge amount of trust because patients don't see. They still have to interpret an x-ray. You see, with a blood test, they don't have to interpret it at all. And every time they go to the doctor, they get a blood test. So a blood test is absolutely normal. It is not abnormal. And by the way, that's what real doctors use, is blood tests. That's why it's called high third-party trust. And they're inflammatory indicators. And the inflammatory indicators, and basically they're blood tests that indicate inflammation. And they are. There's many types, but these are the basic ones. C-reactive protein. C-reactive protein is a highly sensitive one. Sedimentation rate. And your lipid profile. Those are your three core inflammatory and blood indexes. C-reactive protein, sedimentation rate, your ratio of high density to low density lipids. Those are inflammatory indicators. Okay? And remember, we're educating the patient, teaching the education that the healing process is based on the three phases of healing. Inflammation, repair, remodel. So those biomarkers are very good indicators, not only for the initial assessment, but periodic assessments to establish the progress or lack thereof of the patient in the control and management. There's one test that will give you the best control and management of a patient. It's called your inflammatory indicators blood test. That will give you long-term. And I'll explain about on a separate video. I'll explain the importance of third-party objective visual trust biomarkers and how important those are. And they're absolutely vital for chiropractors because we have a 8% utilization and a 67% negative name recognition. So having said that, let's say that you're not using blood tests. And people just seem to get in a panic and a frenzy when I talk about, you know, having your patient get inflammatory blood test work. It's no different how you'd explain that as you explained an x-ray. You explained an x-ray, normal and abnormal. That's exactly what you would do with a blood test. Here's normal, here's abnormal. That's exactly what you're doing with your range of motion. Here's normal, here's abnormal. You're just sharing them normal and abnormal and what it means. That's the simplicity of a test. And of course, it's third-party trust. It has nothing to do with you. So I'll get into that later. But here are the biomarkers. So what is a major key in the report of findings is not to confuse them. In other words, don't take their vision and go everywhere. You want it highly, highly narrow and organized to third-party trust biomarkers. That's where you want all the care based on. Remember, because if it's based on you, they don't trust you. They can reject you. If it's based on them, they want to not stay, not pay, and not refer. They want the path of least resistance. So you never want it based on their opinion, and you never want it based on your opinion. The only person that's going to trust you is a high trust candidate. In other words, a high introduction patient. Well, that's rare. You're not going to be getting all high introduction, high trust people. That's rare. So that's the importance of understanding and utilizing and paying attention to these factors. So we want to narrow their focus. And I would just recommend that you pick your biomarkers, your 3, your 5, your 7, whatever they are. Just stay totally consistent with every patient with those biomarkers and use those biomarkers. And that's what not only their care is based on, that's what the re-exam is based on, and that's going to determine how well they're healing and the need for future care and if there's permanency. In other words, we're branding this. We're making it simple, not making it massive and unwieldy and just going everywhere like chiropractors are so good at doing by being everything to everybody. So we're trying to narrow this, your biomarkers, highly specific to that person's problems. So here's the common biomarkers that chiropractors would use: range of motion, compression test, orthopedic test, x-rays. Those are the 4 biomarkers you'll almost always have positive with every patient. Those are the 4. So having said that, let's go into, we covered the exam. And so remember, I don't want to just say the exam. That's why if I had the exam sheet, in other words, I could actually show them and circle. Remember, anytime I show them a sheet, I never want to show them a blank sheet because their eyes go everywhere on that sheet. I always want to circle or highlight or underline where I want their eyes to go. I want to direct their eyes. So that's why if I'm sitting there knee to knee and I'm going over the test, I'll literally just turn like this to the patient. Here's your exam. And that's the exam sheet that I used. Here's your range of motion, normal versus abnormal. Here's the compression test, normal versus abnormal. Here's your orthopedic test, normal versus abnormal. I'm literally visually, remember the power of visualization, 55% versus verbalization, 7%. That's the power. So I'm using these techniques, communication techniques. So I would point, and then I'm gonna tell them the point of emphasis. So don't go everywhere in your exam. Chiropractors are really good at doing this, especially new guys out of school when you're training them. They will cover everything. They'll cover the posture analysis. They'll cover, they'll just cover every ungodly thing that's irrelevant and confuse the heck out of the patient. So you can't just dump everything on these patients. You got to start narrowing it in highly specific and focusing it directly to. So if you stick with those biomarkers, and you may have 1 or 2 that you like that's kind of consistent, that fits some of these characterizations, visualization, third-party trust. And remember, it also has to be scientific because this information could be subpoenaed. You could, especially when you're doing personal injury, you better not be using non-scientific diagnostic equipment. Some of the classic ones for chiropractors are the subluxation station, neurocolometers, thermographies. None of those are scientifically valid in the court of law. So when I say scientifically valid, I'm talking about what the medical community is using and accepted at large. Or you're going to have, if you have a decent attorney, he's going to destroy you on the stand, and it will all be about false, unscientific data and trust. That's where that's where I would hang my hat. And everything on that, everything else you say will be destroyed because of that. So anyway, having said that, being very careful about your biomarkers, your science-based biomarkers. So we went from the history, we went from the chief complaint, how long it's been going on, anchored, frequency, conscious, subconscious, intensity, scale 1 to 10, reminding them. From there, we moved over to the exam, pointing out the points of emphasis with the biomarkers, and pointing out to them specifically, these are the 5 components. These are the 3 major components. These are the 7. Whatever it is, say what they are. Be highly specific. Here are the 7 factors that are going to determine whether or not you're going to heal normal, abnormal, or have some type of permanent injury. These are the 7 factors right here. That's what it should sound like. Visually, we showed them. Now, we're done with the exam. From the exam, we want to use a 3D model. And all we're doing here is the power of visualization. And so that's the classic spinal model. And so I do recommend having a plastic model of a neck, plastic model of a back. I don't recommend going out and buying every joint there is, every joint of the human body. And I also do not recommend having a skeleton, a human skeleton, or a full spine. When you bring a full spine out, first, it's very difficult to handle. And when you bring a full spine out, their eyes go everywhere. So I do not recommend that at all. You're going to just create more confusion. So that's why I like just a little neck model. I like a little low back model. Simple as that. If it's not a neck or low back, remember, that's 70 to 80% of what you're going to see. If it's not that, then we just won't have a model of the carpal bones because it's not of a prevalence of necessity relative to our practice. So when we do the 3D model, what's the purpose of the 3D model? It's visualization. We're using a 3D model to impact visual and the power, the 55% power of communication with visualization. You always have to explain normal first, always. Front, back, left, right, always. And I'll create a separate video of explaining how to explain these. But anyway, then you're showing them normal and then showing them what their problem is with that model. Done. That goes aside. The next is you should have right near you a spinal chart of the spinal nerves. Now this is a spinal nerve chart that doesn't have everything else. In other words, it doesn't have the organs in it, doesn't have all the muscles. It's just like a skeleton with the nerves. That's it. And there's only one purpose for that. There's only one purpose for a spinal nerve chart. And that is to show the relationship of the origin of the problem and referred pain. Let me say that again. There's only one purpose for a spinal nerve chart. It's to show them the relationship of referred pain. That's it. Now, when you start talking about anything else on that chart that they don't have problems with, you start using, and a common thing with chiropractors is those autonomic charts that have the organs and heart, and then the next thing you know, the person's coming in with neck pain and you're talking about his liver. That goes over really well, doesn't it? So you never want to create confusion and high paradigm shifts. So there is no way I'm going to have that organ chart right now to create confusion. Remember, you start creating and introducing new topics, the natural human mechanism is to go defensive and back away, not come in. It doesn't matter what your philosophy is. That's how they receive it. So that's why you don't want a nerve chart with your autonomic nervous system. In other words, all the crap that chiropractors push. That's not what you want. You want a spinal nerve chart. Now, we'll show them the origin of the problem on the spinal nerve chart, and we'll show them the common referral patterns and the common referral symptoms. Sometimes patients don't know that this can cause tingling or numbness here. And it's not sometimes, it's actually quite often. So we want to make sure that they understand that a problem here can cause a referral symptom somewhere else. And in addition to that, a different type of symptom. So I will say, here's your problem right here. You're having pressure right here, whether it's disc pressure, nerve pressure, joint pressure, whatever, the simple diagnosis that we'll use. This is where it's at. Now you can see this is where the nerves go down into your arms, and this is kind of how it would sound. These are where the nerves go down into your arms, shoulders, and hands. And this is why sometimes you can not only have neck pain, but you can have tingling. Now I will do a menu of symptoms, common symptoms relative to that chief complaint, and it'll sound like that. Sometimes that nerve pressure not only can cause neck pain here, it can cause tingling, numbness, weakness in the hands. Sometimes your hands can even get cold, something like that, feel cold. And I will say to the patient, now, you haven't had any of those types of symptoms, have you? Now, the reason that I'm showing them this and asking them that in the menu is to connect the dots, to create familiarity and simplicity that, yeah, that these other symptoms are directly related to this problem. Okay, so it is not to start piling on. It is not. That is not what we're doing here. And it's so common that patients have a problem and they'll have referred pain that's not pain. That might be tingling, numbness, or cold, something like that, or burning. So I will say, whether it's the neck or the back, I'll say in the neck, like there's three common areas: upper head, neck, and the back. So in the upper head, if it was an injury up higher, I'll say sometimes you see where those nerves go in the back of the head here. So not only can it cause pain at the base of your skull, it can cause headaches, dizziness, blurred vision, irritability, things like that. Now you haven't had anything like that, any symptoms like that, right? Okay. in other words, those symptoms were common. What's key here? Market forces. What is common? We're not going into the 0.001% of symptoms that's studied in chiropractic college. No, we're talking about the real world. So what is common? So that would be some common symptoms, I'd say, in the upper neck. In the neck, in the base of the neck, it would be tingling and numbness, elbow, shoulder, and hands, sometimes weakness, numbness, sometimes burning or tingling. That would be the hand. By the way, it'd be the exact same thing in the low back. If you have pressure in the low back, whether it's disc pressure, nerve pressure, joint pressure, sometimes it can refer down into your buttock or down into your leg, causing your tingling, numbness, weakness, coldness, sometimes even like a burning sensation. Now, you haven't been experiencing anything like that, right? That's all we're doing, connecting the dots to let them know we're in control, we know what it is, and to incorporate these other symptoms and tie it all together. That's it. We're not into, and again, let me remind you, this is not about piling on and going into the autonomic nervous system and how their neck pain can affect high blood pressure. You are asking for them to fire you. It's no different if you went to the dentist for your tooth and he started talking about your foot and diabetes. It wouldn't take very long before you'd want to get the heck out of there. So do not go into this chiropractic terrible way of communicating and terrible paradigm shifts. So that's it. That's the spinal nerve poster. Easy to get. It costs about $25. Frame it, put it up. Should be right next to your view box. Now, from there, we're transitioning into, so let me just do a recap. So we did the introduction. We let them know we're going to take an extra 10 minutes to go over the results of their exam, see where they're at. We reviewed the educational stuff on the board very quickly. We sat down face to face, reviewed their history with an emphasis on their chief complaint, how long it's been going on, anchor, what caused it. In other words, the mechanism of injury, the anchor, the frequency and intensity. Then we went from there to the exam, only focusing on the positive test, narrowing it down to your biomarkers. And I said either use 3, 5, or 7 and put a high emphasis on those 3, 5, or 7, which are very common. Compare that to what should be normal relative to that test if it was positive, let's say, on the left, as explain how it was normal on the right. Putting high emphasis on that these are the biomarkers. These are the indicators of life. You have to have a defined biomarkers that this is, it's called third-party trust. It cannot be you, it cannot be them. So from there, it's the, after the exam, you're going to the model, the 3D model, explaining normal first, then their problem, from there to the nerve chart, and I explain the purpose of the nerve chart. From there, you're going to the x-rays. From the x-rays, now, remember, nothing should be new. There should be like nothing new that they've heard here at all. Nothing. Everything's just, you're doing a walkthrough of everything that's already been covered all the way up to this point. Now, the x-rays are very important because they're visual. They're even more important if you don't do blood tests. And x-rays you're used in chiropractic for patient education, but they're used as biomarkers. They're used for third-party trust is what they're used for. You don't need to show patients x-rays. You do it so they accept so they understand and accept patient care and treatment. That's why you do it. And that's why you should do it. It's called patient education. So what's important about the x-rays is showing them normal. Now I'm going to do a separate video explaining x-rays because there's a tremendous amount of confusion with x-rays and chiropractors. And I'll tell you the key points of what they are. But you always show them normal. Whatever anatomy you're going to show of their abnormal, that's the anatomy you should be showing. So you should always have normal x-rays of the neck, front and back, and flexion extension and obliques, and normal x-rays are as normal as possible. You can typically get those normal x-rays ordered from your chiropractic college radiology department and just order them. They'll charge you $20, $30 and send them out to you. You always show them normal first. You position it properly. So I'm not going to get into too much of the x-rays because that is extensive. The common mistakes that are typically shown: 1, not showing them normal; 2, showing them all their x-rays. You never should show them all their x-rays. You should show them the angle that you're going to show them when you show them their problem, In other words, one x-ray. And typically in the neck, it's a lateral x-ray, and in the low back, it's typically an AP x-ray, sometimes a lateral, sometimes both. But that's typically the spine. Very rare that you show an AP of the neck or the obliques of the neck. And it's the x-ray that is most visually for them. So there might be another x-ray that's clinically important to you, but not something that the lay person can easily see. So typically in the neck, it's the lateral x-ray, and the low back, it's the AP x-ray. Now remember, it gets back to this regular communication. The more x-rays you show them, the more confusion you're creating. So in their chief complaint, you should only show them one x-ray. Show them the normal x-ray. And I put the normal x-ray up there exactly the same way that I'm going to put their x-ray up there. So that's a separate video, because there's a lot of common areas of making mistakes showing x-rays and making a heck of a lot of assumptions, false assumptions, that the patient may or may not do or know or see or whatever. And then remember, there's only 2 times you talk to a patient at a 3rd grade level. All patient education should be at an 8th grade level. Simplicity, simplicity, simplicity. There's 2 times you talk to them at a 3rd grade level. When you're delivering the diagnosis, what is my problem? And when you're showing them an x-ray. And the reason you're going to talk to them as a 3rd grade level, you're going to really dumb this down, is because it is hard and difficult for somebody who doesn't look at x-rays to see gray and white and make any type of interpretation out of it. And if you can remember the first time you saw an x-ray, how strange all that looked to you. So you have to remember that this is all strange and abnormal. Now, I'll tell you a couple of the big problems chiropractors do. They show them too many x-rays. They don't show them normal. And they start talking about all these other problems except their chief complaint. Those are the 3 top problems chiropractors do when they show x-rays. And they just start confusing the hell out of the patient is what they do. So there's only one goal to show the x-rays. Does the patient see the problem? That's the only goal. That can happen in literally 3 seconds. 3 seconds. 3 seconds. With excellent communication, it can happen in 3 seconds. Does the patient see the problem? 3 seconds, you're done. There is not a time gradient on showing x-rays. That's how fast good communication can take place. So from the x-rays now we're transitioning. Now we're going to transition to the board, to the whiteboard. So we're taking their whole problem, the clinical, the markers, everything, and we're going to tie it now right into the patient education. And so the transition before we go are 2 questions. 1, when they see the problem on the board, do you think that's normal or abnormal? We want them to say it, and if it stays like this, do you think it's going to be heal normal or heal with a permanent problem to some degree? I want 2 questions. I've got to get them to answer 2 questions. Those are pain-based consequence questions. Pain-based consequence questions is what they are. So after I showed them on the x-ray if it was abnormal, and again I'm going to do a separate video of a deep dive, exactly the x-rays and all that. But literally, when I finish the x-ray, I'm going to turn to them. I'm going to say, if the patient's named Mary, I'm going to say, Mary, now as long as your neck stays like that, do you think that's normal or abnormal? Do you think that's going to heal normal or heal wrong and eventually cause a permanent problem, giving you some problems the rest of your life to some degree? That's called, and they have to answer that, not you. You're seeing where they're at with all this. That's what you're checking them off and going, where are they at? Do they understand what's going on here? That was the purpose of those 2 questions. That's setting up the consequences. From there, you're going to transition into, you're going over to the board, and you're relating their whole problem to everything you've been talking about with the 3 phases of healing. Now, before you do that, you're now going to ask them the most important question, essentially, that there is. Which of the 3 phases of healing do you want me to help you get back to normal, or as much as your body will allow? That's the question right there. Now, before you ask that, you have to acknowledge the obstacles. And here's the principle behind it. It's called upfront contracting or upfront negotiating. When you state the obstacles up front, there's a psychological effect that it has. It helps to minimize it. When you ignore obstacles, they will come back and kick you in the butt. And the reason people ignore obstacles is low confrontation, low conviction, low confrontation. That's why people fly right over obstacles and don't deal with them or don't talk about them. You have to bring up the problems before they become problems. And by doing so, you're helping to minimize or even eliminate what's going to be or potentially could be a problem. That's the technique. And so we will say something to the effect of, now, Mary, I understand that time, the amount of time it takes to come to a doctor's office and stay in a doctor's office is very important. And costs are always an issue with healthcare. I understand both of those. So you're going to state both of them up front, time and money. You're going to recognize both of them. And by recognizing them, you're also letting their defenses go down by them seeing you recognize and appreciate. In other words, their defenses go down relative to time and money. So we're going to acknowledge the obstacles that we're headed for in all probability. So, and that's what it would sound like. Mary, let me just let you know I can appreciate. And the key word here is appreciate and understand. You will not believe how much those two words can go, how much you can get out of communicating with people when no matter what you say to them, you say those two words before you say what you're going to say. I can appreciate and understand. Those are what are called accepting words. I heard you, I'm with you. And when you say that, I can appreciate, recognize, and understand. You now are letting the other person's defenses go down. That's what's happening when you say that. So that's a very good phrase to say. Now, Mary, I can appreciate, I can recognize and appreciate, the amount of time sometimes it takes to deal with doctors and treatments, and especially any cost or sometimes the cost involved with getting treatment. I just want you to know I can recognize and appreciate and understand that. And I respect that. Okay, so that lets that down. You said it's on the table. Then you're going to just transition your statement. And so, Mary, based on the three phases of healing, the inflammation, repair, and remodel phase with your low back, which of the three phases, and I'm going to say their problem, say the problem was the low back. Which of the three phases of healing in your low back do you want me to help you get back to normal, or as much as your body will allow? That's the question. And then you shut up. And here's a rule. The next person that talks loses. And you just got to pause. And typically right here is I turn away from them. I look at the board and I shut up. And I wait and I listen. It's called active listening. I'm listening for what they say. And I'm listening for three things: major, minor, or curiosity. That's what I'm looking for. Major, minor, curiosity. You're going to get one of three answers: yes, no, or maybe. That's what's going to happen right here. Depending on which one you get is how you're going to communicate next. So you have to know, what did you really hear versus what you wanted to hear. And that is huge. I cannot tell you in all the training I've done how many chiropractors in training think they heard the patient accept care, and they didn't. But that's what the doctor wanted to hear. So he didn't even question anything after they gave a vague generalization, and the doctor moves on, and that's never what they said in the first place. And now you got problems. And that's from bad active listening skills, and it's from bad conviction, bad confrontation. That's what it's from. So that's the statement. And they're going to say one of two things. The repair phase. Which phase? Which phase do you want me to help you get back to normal as much as your body will allow? Now, by this time, this is what's called a no-brainer. In other words, they already should know the consequences, the negative pain-based consequences for each one of these. And so you almost got to be stupid or a fool not to pick them. The only reason you would not is because of the time or money. That's the only reason. That's it. So you're going to state that. Which one of these do you want to get back to normal? They're going to say one of the three. Very, very, very infrequently will they say, I just want to feel better. Just make me feel better. In other words, they'll just go for the pain approach. If they do that, you got serious communication problems. If that's not any type of high percentage, you have serious communication problems. That is very, very it's not even real when you talk to somebody regularly and they see consequences and they understand this process. It's like ridiculous. So that's very rare. The most common answer they'll give is the middle one. Get me back to function where I can move, bend, twist, and all that. The last one, every now and then they'll say it, every now and then, but you have to remember the reason they don't say it. It's not because they don't want it. It's because they're afraid of how much time or money is involved right now. So you have to understand the psychology involved right there. Okay, so if you broke it up, that's kind of where you're at. Whichever one they picked, all we're going to do is match. Okay, so I'm just going to give you the simple example because we're going to go into some more complex answers in a separate video. But let's just take the simple approach now, and let's say, and we'll go with the majority, the one that's most commonly heard. And they'll go, well, the middle one, let me get just back to repair where I can get to that phase. In other words, they know enough consequences that they don't want to just feel better and then have these permanent consequences, but they're not picking remodel because they're afraid of the time or money commitment. So a vast majority of people will say the middle one. And you want them to say it. If they say the middle one, then you just restate the menu and get them to say it. So it would be, let's say they said, oh, the middle one. So the repair phase, is that what you want? Okay. And again, I'm going to have a separate video on this because now we're talking time and money, which is very important. And that deserves a very, very deep dive, not a superficial conversation. But if we're going to make it really simple, this is what essentially all we would do. Let's say they say the repair phase. Then all I'm going to do is take the repair phase and I'm going to remind them. Right now, I'm going to go, well, the repair phase lasts anywhere from 8 weeks to 12 weeks. Okay? Now, depending on you heal, there's two factors that's going to determine how well you heal. One is your age. One is how long you've had the problem. Now, I'm not going to say they're old, so I have to be real careful not to offend anybody here. So I'm just going to say, you're going to lead more toward this direction. You're going to lead more toward this direction. So if at 8 is the low end of the repair phase, 12 is the high end of the repair phase, I'm just going to look at their age. Where is their age? If they're younger, I'm going to go more toward 8. If they're at the old end, I'm going to go more toward 12. If they're in the middle, I'm going to go more toward 10. That's how I'm projecting their treatment based on their age. By the way, these are true physiological facts. How old you are depends on how well you're going to heal. So in the repair phase, we know the time frame is anywhere from 8 to 12 months. I'm going to put up there, 8 to 12 weeks, 8 weeks, 12 weeks, and I'm going to let them know how quickly you heal depends on two things. Mary, one is your age. The older you are, we don't heal as well. The younger you are, heal quicker. That makes sense, doesn't it, Mary? Sounds just like that. Now, I would say you'd be more in the middle, more toward the middle phase. I would never say somebody toward the older unless they were maybe, I don't know, 65 or older. You know, that 65 is already branded in people's mind with retirement. So I would never say that unless they were over 65. So that gives you the time frame for weeks, and then how long you've had the problem. And you should know you did the history. If the problem is recent or if it's been ongoing and there's some degree of permanency, because now this is a re-exacerbation of an old injury. So you should know both of these two characteristics right now. So let's just say it was a middle person, just to simplify this. So the repair phase lasts anywhere from 8 weeks to 12 weeks. One is your age. I would put you more in the middle, more at 10 weeks. And one is how long you've had the problem. It's not a new problem, but it hasn't been going on for years. So I would put you in the middle there also. So you're probably right around the 10-week mark for the repair phase, Mary. So you take that, and all we're going to do now is multiply. The inflammation phase was the first 4 days. Well, we've already seen you for these. The inflammation occurs in the first 72 hours, in the first 3 days. So we're kind of going through that right now. We're finishing up on the pain and inflammation, and then we're going to go into the repair phase. Now, when we see in the repair phase, we treat you about 3 times a week until you actually start showing signs of improvement with your mile markers. And we'd treat you on a Monday, Wednesday, Friday. So, and then we would re-examine you at every 12th visit just to see where you're at. But essentially, if it was 10 weeks, and we're going to see them 3 times a week, I would put on the board 10. Right under 10, I'm putting 3. I'm multiplying out. 3 times 10 is 30. So you have to do this visually where they can visually stair step and go with you. 3 times 10 is 30, 30. So I'm going to stop now. That's how I got to my 30 visits. Okay? They can easily see how I got to my 30 visits. So that's roughly about 30 visits. I'm going to say, does that make sense, Mary? Does that make sense is the key word. Does that make sense? Now, And remember, they just picked the middle phase, so we're not going to talk about anything else. And remember, we'll do a separate video extensively on this communication and the common scenarios in the report of the day 4 of talking money and treatment schedules. What will happen? There's about, I'd say, there's really 3 core scenarios, six top. That's it. So now I've got my visits. I turn to them. Does that make sense? They go, yeah. Okay, they're in agreement with me. Then I match the 30 visits times their copay, whatever it is they're paying. If their copay is $30, and well, 30 times 3, and I'll do it on the board, 3 times $900. That's it. They can easily see how I took their money times that. Now, I don't want to get into copays and partial copays, and they only have so many visits of this or that. That's the separate extended video we're going to go into. So I'm just trying to get the principles and concepts across right here. So that's how I got and that's how they can easily understand and see everything. And by the way, they've committed to everything the whole way. And all of it's based on their motivation, primary pain-based loss. In other words, all the human components of what motivates a human being. So so I would have multiplied that down and said, so basically the cost for 30 visits over the next 3 months would be about, let's say 3 months, would roughly be about $900. Does that make sense, Mary? Now that's how I just got to my dollar amount. Now that's what Mary's paying for the patient. Then I'm going to offer a discount, and we'll talk about the details of this later also. But let's say I'm going to give a 20% discount. Then I'd say, now Mary, by the way, if you do pay in advance, you do get a 20% discount. So 20% of 90 is 180. 180 from 900 is 720. So if you wanted to pay in advance, it'd only be $720. Does that make sense? And then I'm just going to say, are you interested in the discount? That's it. Now, I'll go into some percentages and ratios, but I told you, remember, 74% of my patients prepaid, but of the people who prepaid, only 1 in 4 paid that whole amount right there. 1 in 4. 3 out of 4 had to go to terms. So when I go, are you interested in the discount? And they say, and again, we're just simplifying this. They'll say, yeah, or let's say they say, yeah, then you're done. $720, they cut the check and they've agreed to the price. That won't happen the majority. 1 in 4 times that'll happen with the people that accept the care, generally speaking. 3 out of 4 times, it'll sound something like this. I'd like to, but I don't know if I can afford it, or I don't know if I can do that. Or, in other words, what's the issue? The issue is money. Go right to money. That's the issue. So now, typically right here, I'm going to stop and I'll go back. Well, let me ask you this. Does it make sense, your problem and how your body heals and what it's going to take to get it back to normal without a permanent problem? In other words, I'm going to go back to the clinical and make sure they're totally in awareness and agreement with that, because I do not want to mix clinical with money right now. So I went to money, they're ambivalent, so I'm going to go back to clinical and make sure they're totally understanding and clear with the clinical. Well, let me ask you this, Mary. When we talked about how your body heals and your condition and your history, does it make sense how your body's going to heal relative to the 3 phases of healing? Does that make sense? I just want an agreement, because I want clinical out of the way. What I'm doing is I'm isolating it and getting it out of the way so I can totally go back to money and not have them jumble it all together. So I'm going to go back to clinical, get the agreement, and get it out of the way. Then I'm going to come back to money. So I'm going to stay on money now. When I come back to money, then I'm going to say, well, I tell you what we can do. So in other words, they were ambivalent. And I've got their agreement with the clinical now. Remember, they have agreed with me with the clinical. They've agreed with the problem, the need, how it all works. The need is there. Now what did I tell you we need? All we need to do is go to terms to make this work. And that's what just happened. So when I come back to terms, because I've already got the clinical, I come back to terms and say, well, I'll tell you what, I can understand how money can be an issue sometimes. I'll tell you what we can do is we can give you the discount and divide it up in, say, 3 separate checks. And there's a little psychology in how all this works, and I'll cover it in a separate video. But essentially what we're going to do is just divide it up in 3 separate payments. And so they make all 3 payments today. They do make all 3 payments today. And again, the details of it, it'll be a separate video. But all 3 payments are today. So all we're going to do is say, I tell you what we can do is offer you a discount. Now, you cannot start talking like this if you did not go back and clear out and get the agreement with clinical. You just can't start running them down and running them over. So if they don't go into the agreement, you got to go back to clinical, get the agreement, isolate it, get the agreement, put it on ice, put it on the side. Then make money the issue, because that's what the issue is. So I understand that money can be the issue. I'm just going to say it. I understand how money can be an issue. I'm going to go into agreement with them. I understand how money can be an issue. There's a very big difference by saying, I understand how paying that kind of money up front can be an issue. There's a difference between that and saying, well, can't you afford this? See, that's a very pejorative, offensive language. Can't you afford this? That's a very bad way of communicating. That you're going to get one heck of a defensive reaction with that type of language. So I'm going to go into agreements, understanding. I can understand, I can appreciate and understand. You're going to go into agreements. That's what affects trust, so you can move on. I can understand and appreciate how money can be an issue with healthcare. I'll tell you what we can do. What we can do is we can give you, we can take that $720 and still give you the discount. Just break those up into 3 separate payments over 30, 60, and 90 days. In other words, you'd make one payment. So $720 divided by 3, you just right there on the board, divide it out. So 3 divided into 720 would be roughly 250, 2 something. So we'd have one payment of 2 something today. 30 days from today, it'd be 2 something. And then 30 days from 60 days would be 2 something. Would that be more acceptable and work for you? Now, 74% of my patients prepaid with that technique, 3 out of 4 of them with that technique right there. And all we did is establish the need, make total cognitive sense, and we made it total affordable for everybody. Now, we'll go into these levers. Understanding these levers is huge. The levers being need relative to money. And we talk about money, there's 2 categories. There's price and there's terms. They don't get both. So if you want to charge a lot, you got to go to terms. If you want to charge a little, you don't have to go to terms. But you don't get both. You don't get price and terms. That's not how it works. And almost everybody can afford terms. Almost everybody, unless you got like a ridiculous fee structure. Almost everybody. Remember, there's 6 socioeconomic classes. There's only one socioeconomic class that literally cannot afford chiropractic care. Those are called welfare, survival, homeless people. 5 of the 6 can afford it, but they can afford terms, not necessarily the total price. That's how and why everybody. You don't believe me? See how much a pack of cigarettes cost and how many of your patients are smoking. A pack of cigarettes costs anywhere from $5 to $7. Typical person smokes a pack a day. If it's $5 in 30 days, that's $150 as a smoking habit. A can of Coca-Cola is $1. If they're drinking 1 Coke, that's $30. If they're drinking 2 Cokes a day, that's $60. If they're smoking and drinking 2 Cokes, that's $150 plus 60. You're at $210 just between smoking and drinking 2 Cokes a day. And you're telling me they can't afford care? It has nothing to do with affording care. It has everything to do with values, what they value. That's what it has to do with. It's almost never about money. It's either bad skills, bad communication, bad technique. It's almost never about money. Money is hardly ever the issue. It's relative need relative to terms, 9 out of 10 times. And then if you don't have the ability, the skill set to match those, then they'll take you to their value system, say no to you, and then they'll go buy. They'll tell you how they can't afford your $220 a month, and then they'll spend their $210 a month on their cigarettes and Coke. That has nothing to do with chiropractic or if they can afford it or not. It has to do with your skill level. Okay, so we're gonna close it down right here because I am going to go into a very deep dive with separate videos because of how important the day 4 is, especially talking about treatment schedules and money and biomarkers and things like that. But essentially, you got the gist of the flow all the way through day 4. Nothing new happened. Introducing it all, establishing the need, going to money, connecting everything you taught them with the 3 phases healing to a schedule, connecting the treatments to the money, multiplying the money out, gives you the money relative to the treatment schedule. Remember, they picked it all, had nothing to do with you, and then you going to terms with the money And 3 out of 4 people, I just tell you, over 50% of your people will prepay with this. You get 50% of your people to prepay for their care, you have got one heck of a practice. You've got a lot less problems at your front. You got a lot less dropout rates. You're not chasing patients. It makes one huge, massive difference when you get patients to prepay. But it takes confrontation, conviction, and skill set and knowledge. And that's the difference between people who do exceptionally well in any business, not just chiropractic, in any business. Do they put the time and effort in to develop their skill sets and their knowledge to the income level they want, versus not developing their skill sets and knowledge, being chicken, having low conviction, low confrontation, not doing anything about it, but wanting to make a lot of money? That's totally incongruent. It doesn't work that way.